Good afternoon and welcome to the NCCN Best Practices webinar series, COVID-19 and Cancer Center operations. My name is Theresa Franco. I'm the Vice President for Cancer Center Clinical Operations and Pharmacy Services at the Fred and Pamela Buffett Cancer Center at the University of Nebraska Medical Center. I also serve as a co-chair for the Best Practices Committee. In today's webinar, we'll be discussing how cancer centers utilize network satellite locations during the pandemic and what the implications are for the future where oncology is concerned. We'd really like to thank our sponsors for without these organizations, it would not be possible for us to share these very enlightening presentations. We greatly appreciate their contributions because without them, none of this would be possible. So let's get started with our speakers for the seminar. I'd like to introduce all of them. Our first presentation will be by Beth Souza, who is the Senior Administrative Director for Admissions and Operations at the Massachusetts General Hospital Cancer Center. In her role, she oversees operations of the main cancer center, as well as operations and integration of the community-based Massachusetts General Cancer Centers. She has a master's in healthcare administration from Southern New Hampshire University and over 25 years of healthcare management and healthcare operations experience. Her partner for this presentation will be Dr. Ephraim Hochberg, who is Assistant Professor of Medicine at Harvard Medical School and the Associate Clinical Director of the Massachusetts General Hospital Cancer Center. He oversees clinical operations across the cancer center's inpatient and ambulatory environments, as well as numerous satellite locations. Dr. Hochberg specializes in the treatment of patients with non-Hodgkin's and Hodgkin's lymphoma, and additionally, he serves as a medical director of international services for the Massachusetts General Hospital. Our second presentation will be done by Dr. Larry Shulman from the Abramson Cancer Center. He is a professor of medicine at the University of Pennsylvania and deputy director for clinical services of the Abramson Cancer Center and director of the Center for Global Cancer Medicine. He is a specialist in the treatment of patients with breast cancer and currently serves on the National Cancer Policy Forum of the National Academy and is a member of the NCCN Best Practices Committee. Before we get started, I want to remind everyone and encourage everyone that if you have any questions during any of today's presentations, please submit them through the Q&A box located on your screen. We should have time to address a multitude of questions at the end of the webinar. So now, without further ado, I will hand it over to Beth and Dr. Hochberg for our first presentation.
So I wanted to start off this afternoon talking about the Mass General Cancer Center and giving some overall facts for our cancer center. We have 14% of the market share in Eastern Mass. We're ranked number 18 in the 2020 and 21 U.S. News and World Report rankings. We have over 30 multidisciplinary disease centers and programs. We have a network infrastructure, which includes 4 satellites and 10 plus affiliates, and that's what we'll focus on our discussion this afternoon. And we're an NCI designated comprehensive cancer center. We see around 120,000 ambulatory outpatient visits a year, with which about 22,000 of those are new patients, with around 9,600 inpatient admissions, 65,000 chemotherapy infusions, and a $700 million cancer service line. This is our Mass General Hospital Cancer Center network. And what you can see here is that we have 12 sites. Some are owned and operated and part of the Mass General Brigham family. Others are affiliate locations with a range of services and levels of integration. And what you see is they are predominantly located in the New England states, but we do have some relationships that we have in Florida. Now I'd like to focus in on what we call our near network sites, which are closest to the Mass General main campus in Boston. You can see Mass General North Shore Cancer Center, which is 19 miles from our Boston hub. as well as our cancer center at Newton Wellesley, 12 miles from Boston, and our Mass General Cancer Center at MGH Waltham, which is around 18 miles from the city of Boston. And what we want to talk to you today about how those sites at Danvers, Newton Wellesley, and Waltham were integral to the work that we did during the time of the pandemic. When the pandemic hit Boston, we were faced with some significant challenges. We were limited in our practice capacity. We had a threshold where we could only see 2 in-person patients per hour at a maximum. We had 1 suite, which is 25 of our exam rooms, which is designated as a hospital outpatient COVID unit. Our staffing capacity in the ambulatory setting limited us to have a physician or an APP of the day model in our outpatient practice setting, where we had 1 or 2 physicians and 1 to 2 APPs on site in each disease center, depending on the size. And we also had challenges with the MA staffing and workload, given the new restrictions that were placed with the cleaning and other opportunities that we had to make sure we were focusing on during the time of the pandemic. We also had to reduce our Boston infusion capacity by about 25 treatments per day to meet the social distancing and density requirements that were implemented at the hospital at that time. And also, because of the work that our team does caring for cancer patients, they were often redeployed within the institution to help with COVID-related activities on both the clinical and the administrative side, further placing strain on the staffing model that we had in our ambulatory setting. Our leadership team was also deployed to manage some hospital COVID operations. Now I will hand the presentation over to Dr. Ephraim Hochberg, who will speak on how we transitioned patient care to the near network sites during the pandemic.
I wanted to thank the organizers very much for inviting me to speak today. We divided up our thoughts on how we transitioned care at the time of COVID into 3 timescales or 3 levels of strategy. We had our immediate concerns around where we were going to take care of the new patients who are continuing to come to our cancer center, our established patients, and our infusion visits. And this we had to figure out within the first couple days or week once we had our break and began to care for patients under COVID. Once we'd come to terms with a little bit of those issues, we began to think in longer terms, how could we move patients and, between sites by moving their providers? And this was our short-term reallocation strategy. In this bucket, we also put our expansion of clinical research at network locations. We recognize that some of our capacity limitations were actually due to the inability to provide the full scope of services at our core Boston site. Finally, we had some long-term changes that have taken about a year to implement in the setting of COVID. And these are changes that we've thought about for quite some time, but were really accelerated by the pressures COVID placed on us. These are moving programs between sites and bringing new operating rooms and LINACs available to bring care out to our networks. So I'll start first by talking about the transition of care for new patients. As Beth mentioned, we see about 22,000 new patients a year. And of course, they're highly varied in terms of their location they come from, the expertise they require, their need for clinical trials, and their need for complicated multidisciplinary care. So how do we think about trying to move patients across our system? So our solution for this was we took our current new patient access nursing team. We have 11 nursing FTEs who triage all new patients and determine how they can be cared for. And we moved those new patients, both to existing providers across our network, but also to virtual slots and virtual clinics that we developed at our Boston campus. Although we should make the point that we think of our providers as situated in a specific location, i.e. a Boston provider, but in the virtual world, there's no reason that still has to be true. And that's a challenge we're still trying to face now. So in terms of physical movement of patient, you can see on the left-hand side in the gray box, our Boston volume dropped by about 6%. Our Waltham volume for new patients went up by 25%, 3% at Danvers, and 11% at Newton Wellesley. I would say this was not unselected growth at these sites. We were trying to think already about our long-term strategy for the programs we wanted to grow at those locations. So in Waltham, we specifically grew a hematology practice, benign and malignant, as well as a breast oncology practice. The transition to virtual care was also fascinating. We've been trying for years to expand our utilization of virtual care. And with the exception of our neurofibromatosis clinic and some breast cancer providers, we'd had less than 1% uptake in the bottom right-hand corner in the blue box pre-pandemic. But by May of 2020, 61% of our new patients were being seen virtually, and that's actually persisted to a great degree with about 45% as of March. What was really important to recognize is that each specific oncologic disease has dramatically different requirements for in-person care. Benign hematology in our GU multidisciplinary clinics were about 90% virtual for new patients, whereas breast oncology and head and neck oncology were less than 20%. We began to recognize that our moving patients to network locations required that we standardize our workflow across sites. We had assumed that our templates for each of our physicians and APPs at every site were the same. But it turned out we had a number of physicians whose standard was that a scheduler would call them and say, hey, can you fit in a new patient? So we had to rebuild our templates at our network sites to make sure that the new patient appointments were pre-designated and able to be booked from any location. We centralized our new patient phone calls as opposed to a primary care provider at a site calling directly to the practice that may be in the same building for a new patient appointment. Instead, we centralized those phone calls into Boston to allow us to adequately determine which patients had to be seen at a site. We also had to work on comfort for individual providers as well as for administrators in transitioning new patients between sites into the network. We had a lot of folks in various roles who've been taking care of new patients and triaging them successfully into Boston for 10, 15, 20 years. To get them to understand that our new model was care distributed across the network was quite a significant change management challenge. The last point we recognized is although we all think that virtual care is devoid of infrastructure requirements, that is very far from the case. Once a patient had been seen in a new patient appointment virtually, they still had very significant follow-up needs. So we developed a medical assistant / scheduler virtual care coordinator role. This is a remote role that would help that patient book the follow-up appointments that are required coming off of a new patient multidisciplinary appointment. Lots of challenges were also faced. Some of the biggest challenges were centered around our compensation models. So especially with our surgical and radiation oncology colleagues, where a compensation plan is more heavily focused on personal RVU generation, there was real concern about losing cases in this model. And we had to really have long discussions, and I don't think we fully settled out around how we're going to make sure this isn't an issue. The same things were true, although less so in the medical oncology side. One of our greatest challenges, and one that we really haven't faced completely, is that prior to COVID and the dramatic expansion in virtual care, our application of the letter of the law around virtual care out of state was less stringent than it should have been. But after discussion with our Office of General Counsel, we now have very stringent licensure-based requirements for providing virtual care out of state. So the care that we were providing in our stem cell transplant group, 50% of whose cases come from out of state, those providers now have to require licenses in those out of state locations. We have lots of work still to do with new patients. We want to expand this to more network locations, but we had a bigger challenge by an order of magnitude in the next problem I'm going to address, the established patients. So here we had almost 10 times, 15 times the number of visits to manage. And we really didn't have systems in place to move those patients between sites. Established patients especially are very tied, and that patient-provider relationship is incredibly important to maintain. That was a major hindrance to us. We also had lots of issues with site-specific scheduling and follow-ups that we had to manage. So our solution was to think about making some of those subspecialty providers and some of those subspecialty relationships on which patients relied available at our network sites. An easy way to do that was to transition some of those care elements to a virtual arena. The patient could still see the same provider, but it was now on Zoom as opposed to in person. So we moved again, as the prior figure, from about 1% to about 65% established care, and we've settled out around the 30% range. And again, on the bottom right corner, you can see there's wide variability in the adoption across subspecialties. And that's a tension point that we'll come back to. We were able to decant a significant amount of care to our near network, especially situations where the provider already had some template on site at those locations. In a small percentage of cases, we were able to move patients between providers, but that was an option of last resort. So some of the issues that we needed to do in order to allow patients to decant to some of our network locations were to make sure that we had standardized visit types. So we could tell in every schedule what the follow-up appointments were, what the patients were going to chemotherapy were, how long the appointment lengths were, so we could have a stable platform within which to implement these changes. This also drove greatly increased collaboration between Boston and our network locations. We developed across each of our disease centers very sophisticated multidisciplinary tumor boards for complex cases with live pathology, radiology, presentations from network sites and Boston sites to ensure that we still had collaboration around complex patients. We also developed Epic-based reporting to ensure that patients with a primary address in a specific geographic area could be triaged back to that area. And we expanded our virtual care coordinator role into our near network locations to help support virtual care at our network sites. Another major challenge that we faced, similar to the scheduling challenge I spoke about previously, is that individual sites felt very strongly about ownership of their provider schedules and availability. We uncovered that a number of our sites were functioning a little bit in a historical private practice model. My scheduler, my medical assistant, my nurse, and that the ownership of those schedules really was a significant barrier for us in terms of our ability to move established patients onto those schedules. The patients wanted to see their specific provider. The provider didn't mind going to see patients at more than one site, but it turned out that once you got to a third site, things got really complicated. So providers driving up for clinics to Danvers, then down to Waltham, and then to Boston really generated a lot of concern. So we stepped away from that. Another major barrier, or not barrier, but I think strength consideration that we had is that we have a very strong primary nursing model. Every patient who we see is assigned a primary nurse, and they will see that nurse for every single infusion that patient has for the duration of their time at the Mass General Hospital Cancer Center. Trying to ensure that we maintain this as much as we could, or recognize that we were pushing up against a core tenet of care if we had to change it, was a really important consideration. Often our nurses are the people who have the greatest impact on a patient's experience at our cancer center. Finally, we had to think about what our footprint was at each network site. Were we growing haphazardly? Were we just pushing patients out into the network in order to decrease our volume at our Boston campus? We tried not to do that. We really tried to align with a longer term strategy I'll get to in our third step. So the last piece that we had to work on was our infusion volume. Beth mentioned that we dropped our infusion capacity by 25 visits per day. We run our infusion room in Boston 7 days a week. You can see the significant volume from Monday through Friday, and then lower volume Saturday and Sunday. And we really didn't have any ability to know what the day-by-day capacity was at our network sites, short of calling the site and asking them. So we developed this integrated dashboard of infusion availability. So we could look that on May 12th, Boston is 19 patients over capacity. But if we look in Waltham, the top right corner, Waltham is at capacity. Newton Wellesley has capacity. In fact, they have a 19-person capacity. So when a clinician asked us to get a patient in, and they were frustrated they couldn't get the patient in Boston, we can immediately point across our network and identify these opportunities to decant patient volume. This is difficult. You have to share the same EHR. You have to be able to put orders in. You have to have a standardized D-link process. In other words, if you're going to have a patient seen for chemotherapy and there's no provider on site who knows that patient, you have to have a virtual visit and a locally drawn lab and clear those patients for treatment before they go in for infusion at a site where they've never been seen before. We partnered very successfully with Quest that allowed us to draw our patients' labs at a nationwide series of laboratory sites and directly flow them into our EHR to clear patients. We also were able to move some infusions to home infusion, although that's a very complicated challenge we can raise in another conference. The last point I'll raise is some of the significant challenges we faced in the care of some of these patients. It's not enough to write a note that you've cleared a patient for therapy. In many of these cases, patients are fragile, and having a good clinical pass-off between a treating team who's 20 miles away and the on-site nursing staff is incredibly important. So we developed processes so that those communications could occur easily. What happens when a patient's being treated at a site, their provider's not available, and in fact, their provider's not working that day and is unpageable? Who manages changes to the orders? Who adds additional antiemetics on? So this required significantly increased clinical care at some of the sites to accommodate. The scheduling and coordination of care only gets more complex the more sites you add. The figure to the right is one of the things we are the most proud of. And this is a system called opt-in, or optimizing infusion. We worked with an MIT process improvement team, and what they did is built a theoretical model of the maximal number of infusions that could fit, given dependencies on minimizing the wait time between appointments and infusion, and also taking into some account patient preference. So what this shows you is our baseline in the light gray curve, our schedule control, and then an opt-in in the orange curve. And this is the exact same infusion unit, but our occupancy increased by between 5 and 7 chairs at any time of the day by running every scheduled infusion through this algorithm and having the algorithm pick the time of infusion that was most likely to optimize capacity. This is a system I'm showing you because it's only available at our Boston campus. But as we think about our directed scheduling into our network locations, using our network dashboard I showed you here, our goal is to get to the point where this system will optimize infusion across every site in our network, taking into account patient geography and delinking. So that's some of the things we try to do immediately: move new patients, move existing patients, and move infusions. We recognized over the summer that that was insufficient. And so we began to think about ways in which we could move more volume to our network sites. And we recognized that we couldn't move a neuro-oncology patient unless we had a neuro-oncologist available. So how did we do this? We began to think about our providers on site in Boston who had the capacity to take on some additional volume, where we had the clinical rooms and the infrastructure, neuroradiology coverage, that would allow those specialty sessions to be loaned transiently to our network sites. So we moved neuro-oncology in one example to 2 of our sites, GYN oncology to 2 of our sites. And this really gave us the opportunity to move a whole additional group of patients out to sites where they normally had not been seen, with providers who are subspecialized. There are enormous challenges here. If you're only going to have a specialty provider available for half a day a week, who covers the phone call in for a neuro-oncology patient? Who tapers or increases their steroids for neurologic symptoms? How do we manage clinical research infrastructure across sites? If a patient is really interested in a clinical trial or is approaching a clinical trial, how do we get them to the right side of care? We also have varying RVU models in an academic site versus a community site, and this began to alter the way people are paid the more time we have them at network sites. We do see this as the future, though. We really want to have at least our near network sites able to support all of our clinical research with the exception of first in human and phase 1. We are thinking about how to expand our advanced practice provider resources to support physicians across all of these multiple sites. And we're offering many more virtual specialty clinics out of our network sites. Maybe we don't have to send the neuro-oncologist, they can Zoom into our network site. Finally, and this is my last slide, we began to think, and this is things we've just implemented now after about a year, how we move full programs between sites. Do we really want in the future a significant number of patients to drive past our Waltham campus to come in and get breast cancer care for non-clinical trial breast cancer patients in Boston? The challenge is that our disease center leadership across our disease centers had very variable buy-in on their interest in supporting these network sites. So we had to do a lot of change management and discussion around how we create a structure that meets the needs of providers and patients in each of these locations. What services are needed at that location within that infrastructure of care to provide good support for providers? How do we make sure patients get equitable care? If we have patients who live in downtown Boston, a 2-minute drive from our main Boston campus, we can't very well move their care 25 minutes west. Our next steps are how we develop allocation criteria, and this is what we're working on now. With the limited number of exam rooms we have available in Boston, who should use those exam rooms? Is it research care? Is it multidisciplinary care? Is it urgent care? And how do we make sure we have the resources available at each site to support the broad movements of most of a clinical program to some of our network locations? Beth, I'll turn it back over to you.
So where do we go from here? As we plan for a new building in Boston that will house outpatient and inpatient oncology starting in 2027 and completed by 2030, we want to ensure we focus on the strategic alignment of programs at the near network sites, as Dr. Hochberg just alluded to ensure that we have the high intensity complex care occurring in the Boston site and have our network sites closely aligned with our strategic vision. We want to continue to do capacity evaluation. As Dr. Hochberg mentioned, we are looking at all of our space and how it's being utilized in the most effective manner. We want to ensure that we're maintaining our virtual care model. We've set 30% of our total volume to remain virtual on the Boston campus. We're trending down from the high of where we were post-pandemic at 40%. We're starting to go closer to the 30% and certainly hope that we can maintain that level, because that is what we need to ensure that some of the work that we did during the pandemic to accommodate all the patients who choose to have their care within our Boston campus for our near network sites are able to do so. And we know that virtual care will afford us that opportunity and our patients that opportunity as well. And we also want to prioritize our clinical space post-pandemic. We used the suite that initially was used during COVID times for COVID care and have actually realigned that exam room suite to be focused on our phase 1 in our research program. And so we've made a strategic decision, and now we want to continue to evolve that model as we move into a new building, as I mentioned, in 2027 and then in 2030. It's two buildings that will come together and have one ambulatory footprint, where we will have 120 exam rooms and 100 infusion chairs. And we do believe that the work that we've done through the pandemic and the collaboration and support that we've had in our near network sites with our ongoing integration and partnership will serve us well to allow us to move into the new building, take some of the lessons we learned from the pandemic, and evolve cancer care for the future. Thank you.
Thank you, Beth and Dr. Hochberg. That was excellent. And it really gave us a lot of insight on how you utilized your network locations to mitigate your capacity constraints during the pandemic. Very impressive in how quickly you were able to change course to provide excellent care to your patients. So congratulations on what you've accomplished. Now we're going to move into our second presentation. It's going to be done by Dr. Shulman, who from the Abramson Cancer Center, and I'm going to let him take it away. Go ahead, Dr. Shulman.
Thank you so much, Theresa, and thank you everybody for joining today, and good afternoon. So I'm going to tell you a story that's actually not that different from the story that Beth and Effie just told you about Mass General. But I'm not sure that we were quite as organized as they were. They're terrific. So this is the University of Pennsylvania Health System, and we own 6 hospitals. The Hospital of the University of Pennsylvania, all the way on the left, is our main academic center. It's by far our largest center, where all the care is super subspecialized. Even within the disease groups, there are subspecialized people. We have 2 other hospitals in the downtown area, in the red circle or the red square. One is Penn Presbyterian, which is a mile or 2 away from our main hospital, and the other is Pennsylvania Hospital, which is on the other side of town. But all 3 of those hospitals are within Philadelphia proper. We then have 3 hospitals that are outside of Philadelphia: Chester County Hospital, which is west, of Philadelphia, but within striking distance, so to speak. Lancaster General, which is way west, about an hour and a half to 2 hour drive, depending on the day, and Princeton Medical Center, which is in New Jersey, further north. Several of these have associated ambulatory centers, none of which are located within Philadelphia. So at the Hospital University of Pennsylvania, we have 3 in Valley Forge, Radnor, and Langhorne, all in Pennsylvania. And I will say that one of the things that happened here was, as I think was the case with Mass General, we were making plans to expand our community practices before we ever heard of COVID. And so Radnor was already under construction to open a new building that would triple the size of the old building in preparation for greater demand in the suburbs. For Penn Presbyterian, the Cherry Hill site was also a relatively new site, opened only about 2 years ago. It is a beautiful site and really quite large and heavily subscribed. So we had started to think about movements out of Philadelphia for the same reasons that Effie mentioned. You know, why should somebody drive past one of our centers and come into Philadelphia, which is painful from the traffic point of view and also painful from the parking point of view. There are a couple of other things that I should mention as an introduction. First of all of our sites are the same EHR. They're all on Epic and on the same instance of Epic, except for Lancaster General Hospital. And they are on Epic, but a different instance of Epic. So that everywhere else in the system, everything is integrated into the same EHR. The other thing that I wanted to mention as we started was, as I mentioned, at the Hospital of the University of Pennsylvania, and you'll see the relative volumes in a minute, everyone is subspecialized, but in the other downtown hospitals, there's some who are subspecialized and there's some who are generalists. And in our community hospitals, everyone is a generalist oncologist. That goes for medical oncology and radiation oncology. Surgical oncology tends to be somewhat more specialized, as you would expect. But again, before COVID, we had started to think about and started to move towards specialization at our other sites. And it was clear for a variety of practical reasons that one of our oncologists at Chester County could not see just sarcoma or just lymphoma because the caseloads were very variable there. But somebody could become concentrated in that area and link more into our main disease groups downtown and become, if you would, an expert in that area. And that was one of the things that we started to do again before COVID. So all of you, I'm sure, remember, and I try to remind myself that a little over a year ago in March of 2020, we were pretty uncertain and frankly, pretty unnerved by what was going on. We really didn't know what to expect. We really didn't have a great idea about how to keep our staff safe, our patients safe, what precautions would work, and so on. And if you recall, there were shortages of PPE equipment. We were rewashing N95 masks and so on. And we also had no idea what the COVID positive patient demands and numbers would be on our individual hospitals. And we had no idea how the patients were going to react to the pandemic. So I'd like to tell you that we were as organized as some of the work that you just heard, but we were trying to figure it out as we went along. And one of the first things we learned about was that the rates of COVID and demands on COVID patients, the numbers of patients in our hospitals, varied by time. Princeton, which is very tightly connected to New York City, actually was the first of our hospitals to become overwhelmed by the number of COVID patients who were hospitalized, pressures on the operating rooms and on the ICUs. And it paralleled a lot of the spike in COVID cases in New York, particularly in Queens. And we were watching that from the other sites. Next, the Hospital of the University of Pennsylvania and Penn Presbyterian spiked and became really quite inundated with COVID patients, particularly Penn Presbyterian, which serves a lot of our underserved community. And Lancaster actually spiked much, much later, months and months later. So, you know, we had to take all these variations into consideration. When appropriate, like everywhere else, we had a rapid shutdown of non-essential services, of screening, of surgeries that were not critical, and so on. And we did that as a reflection of what the overall COVID demands were in that hospital. But frankly, they were much higher in the downtown hospitals than they were initially at either Chester County or initially at Lancaster. And of course, our ambulatory sites, which I mentioned, were not under the same concerns because they didn't have inpatient units and they weren't housing COVID patients. The other thing that happened is that in Philadelphia, a lot of our population relies on public transportation. We actually have quite a wonderful public transportation system in Philadelphia and the surrounding suburbs. But that was largely shut down, and what wasn't shut down, people really just didn't want to get on public transportation, and you could understand that, and that affected our downtown hospitals to a greater degree. By mid-May of last year, just a year ago, we were much more secure in infection control and resource management. And we started to open up screening, we started to open up surgery, and we frankly advertised to our patients in the greater Philadelphia area that it was safe to come in for cancer care. And in fact, it was much more concerning to delay your care, either initial diagnosis or ongoing care, rather than to come in to our sites. And we felt that all of our sites, in fact, were in quite good shape in that regard. But frankly, the patients had different thoughts about that. They were reluctant to come, particularly to the downtown sites. So when we opened up mammography screening, for instance, at our Philadelphia hospitals, we started calling patients who had missed their screening in April because the screening was shut down. And a large portion of those patients said, well, they'd rather not come in now, they'd rather put off their screening. And that was clearly true also for patients who were developing initial symptoms, yet undiagnosed with their cancer, who were staying home because they just didn't feel comfortable coming in. So a year later, what have we learned and how did we manage that? How I'm presenting this is a little bit different than Effie and Beth did, but what we learned was that the patients really drove us to push care out of the downtown hospitals and into our community hospitals and into our community sites, and I'll show you some of the data for that. We had a much higher use of telehealth downtown. We got up to probably about 40% or so of our care being delivered downtown by telehealth, but the suburbs were able to accommodate many more of their patients in person. They did telehealth, but they did a lot less of it. And a lot of our infusion volumes, as I will show you, moved to the suburbs, some under the care of the oncologists in the suburbs, but also some continuing to be under the care of the downtown oncologists, partnering with APPs and local oncologists in our suburban sites. So this is just a graph of total visits by hospital, and all the way on the left is July of 2019, where we had no idea what was coming. You can see the dips that occurred in March and April and May of 2020, and then the data goes up through January of 2021. So the line at the top is our main academic hospital. As I mentioned, that's got by far the largest volumes, and there was a tremendous dip in total visits, going from about 12,000 a month down to about 8,000 a month. So that was literally a third of the patients not coming in. And when you look at the lines below that, which are our other downtown hospitals, but also our community hospitals, the dips were in fact much less. And the recovery was somewhat quicker. If you look at visit volumes, either total visits or new patients, if you look at the downtown hospitals and compare July through March of 2020 through 21, which is FY21, versus an equivalent period of time in 2019, entirely before COVID, you can see that in our downtown hospitals, total visits increased by only 1%, and new patient visits increased by 4.8%. I mean, usually there's fairly good growth year to year, but here, over a 2-year period, in 2019, in fact, was a very busy year. Basically, the downtown total visits were flat, and there was a slight increase in patients. If you look at our regional hospitals, though, total visits were up 12%, and new patient visits were up 16%. And I'd like to tell you that was all planned, and eventually, as I will show you, there was some planning to that, but a lot of this was just driven by patient desires. In the New Jersey suburbs, total visits went up 12%, smaller increase in new patients, but we felt and we could show that that reflected the downtown oncologists sending many of their patients to our Cherry Hill, New Jersey facility for their infusions. And then our other Pennsylvania outpatient facilities, you can see total visits were up 13%. And we opened that new facility, and our new patient volumes at the Radnor facility went up by 46%. So a big difference between the volume shifts downtown versus our other sites of care. And just as an example of the types of things we were thinking about, we looked at infusion volumes for hematologic malignancies, because so many of those patients are in fact cared for downtown by the super specialists and traditionally got their treatments downtown. We figured the downtown infusion volumes for these patients would be better preserved. But again, if you compare fiscal year 21 to fiscal year 2019, you can see that in fact there was a 20% drop in infusion volumes for the hematologic malignancy patients downtown, whereas in New Jersey suburbs and Chester County increased dramatically to make up that difference. Patients shifted their infusion care elsewhere. And to the other Philadelphia suburbs, there was less of an increase, but part of that had to do with the transition to one of our new facilities. So again, I think the patients were speaking with their feet, but also it helped us to accommodate the problem. So why did all this happen, and why did it happen somewhere? And I think that part of the issue is that suburban sites of care more securely adopted safety procedures. And I think that it's really just a reflection of the fact that our downtown main hospitals are huge. And the number of patients who generally would come into those sites of care were very large. The number of staff that came into those sites of care every day was very large. And shutting those down, trying to reduce just the physical volumes of both staff and patients required reasonably drastic action, whereas our suburban hospitals and our suburban ambulatory clinics are much smaller. And they could adapt their staffing models and keep social distancing and masking and other criteria that we use for safety much more easily, while still maintaining a relatively high number of in-person visits. So a larger percentage of staff were on site at the suburban sites, and more in-person visits versus telehealth visits were maintained in suburban sites. These units were just much easier to manage through the early phases of the pandemic than our very large academic centers. In addition, the tumor boards all became virtual, and there was a dramatic increase in active participation from our suburban site clinicians. And this really changed the relationship between our community oncologists and our specialists downtown in a very, very rapid fashion. Part of this was due to the fact that we were all now in the same, equal playing field, if you will. In the old days, where we did offer video access to our tumor boards, there was the in crowd sitting around the table, chatting and whispering to each other. And then there were the people who were on video who were really in a different class. Now everybody was the same little square on the Zoom screen, if you will, and had really equal footing. In addition, we all wanted to figure out how best to care for our patients, considering how COVID was changing how we delivered care. And so, for instance, the breast group in March of 2020 went from having 1 tumor board a week to having 3 tumor boards a week, where each patient was discussed in light of OR restrictions and other restrictions and so on. And the community oncologists really wanted to participate in that. The other thing that happened with this, of course, was that there was much more shared care. That one of the downtown oncologists would say to their colleague at another site, listen, I have Mrs. Jones, she's doing great, she lives out near you, can I send her out to you for your care? And happy to stay in touch with her, and so on and so forth. And some of that actually was reflected in initial telemedicine visits with the downtown teams, often their initial consultation, but then deciding with the patient that they live near Radnor, they live near our Valley Forge site, and that they should go there for their care. And so this wasn't maybe as well orchestrated as the MGH group has done, but I can tell you that the results were very, very similar. And part of the results of this, as I mentioned, was the oncologists in the community started to view themselves as subspecialists, and we were able to start to focus our efforts on moving higher end care to the suburbs via collaboration. So now what? As things are loosening up in Pennsylvania and New Jersey, a lot of the restrictions have been eased, and our sites are opening up fully. We've thought a lot about this, and we're now thinking about accelerating specialized care development at our suburban sites. We had started this before COVID, as I mentioned, but we had this traditional model of oncology generalists, and it wasn't going very quickly. But now we've embraced the hybrid model of areas of concentration for our oncologists who are in the communities, linkage with the downtown subspecialized teams through virtual tumor boards and virtual research meetings, increased shared care. We have much more comfort moving patients back and forth, and the patients have more comfort in doing that, and an increase in the high-end care that we're able to safely and effectively deliver to suburban sites. In addition, clinical trials development in our suburban sites has been an area of focus. Again, this was beginning to happen before COVID, but again, has caused us to accelerate this with building clinical trials infrastructures at our suburban sites, having disease-specific physician champions, a breast champion and a lung champion at different sites, and telemedicine for remote screening of patients who might be eligible for clinical trials downtown. I will say that we think a lot about telemedicine. We don't have the same goals that I think Beth mentioned in her presentation. We're also unclear about how they're going to be reimbursed or not. So we're doing a lot of thinking about what telemedicine is going to be like in the future. There are a few issues, and I think they're some of the same ones that Effie and Beth mentioned. The financial incentives are not in line. Hospitals are responsible for their individual bottom lines. And if we shift patients from one hospital to another, it has implications for both of those hospitals. The physicians are responsible for RVU production, both medical oncologists and surgeons, as well as the radiation oncologists. And though I think everybody did exactly what needed to be done in the best interest of the patients, there are implications for the movement of patient volumes between sites and between specialists. And there are movements of ancillaries, so that we might be seeing a patient downtown who needs a follow-up CT scan or MRI, and we schedule that for one of our suburban sites because it's near where the patient lives and the patient feels more comfortable getting it there. And as I mentioned, we moved some of our infusion to suburban sites, even if the primary oncologist was at a downtown site. There are some capacity issues. Our suburban sites, with the exception of the new one that we opened, are all pretty busy. They don't have a lot of extra capacity. And we're now starting to think about building some of those sites out to increase their capacity. But they were great about managing the shifts in care, but they didn't have unlimited capacity either with personnel or space. And frankly, we're about to open a huge new inpatient facility at our main location. Should open in the next 4 or 5 months. That was something obviously planned long before COVID, and the hospital administration, not inappropriately, is worried about filling all of those new beds. So this has been a learning experience, if you will. I think it will result in lots of good changes in our system, but we're still in the middle of adjusting and trying to figure out what the best path forward is. I think that's my last slide, and I'll end there. Thank you very much, everyone.
Thank you, Dr. Shulman. That was a fantastic overview of what's been happening in your facility from a standpoint of optimizing your locations in light of what's happening with the pandemic to ensure cancer care for your patients. I'm going to ask Dr. Hochberg and Beth to come back on the screen. I'm going to continue to encourage you to put questions in the Q&A so that we can address some of your issues. I will start with one that I think really be interested in hearing from both centers on, is a question about how did you respond to patient concerns about, going off the main campus and feeling like maybe they weren't going to get the same standard or same quality of cancer care that they were receiving when they were coming to the big house. So do you want to, Dr. Hochberg, do you want to start?
Sure, yeah, I'm happy to start. So I would say that it went in 2 directions, interestingly. We had a number of COVID fearful patients, appropriately, who viewed our main campus and the never-ending drumbeat of news reports about the 350 COVID patients and 170 vented patients we had at our main campus as a real area of concern, and they wanted to avoid the main campus at all costs, and could we arrange for them to be seen in the community? And then we did have a number of patients who felt that they really wanted to see the specific surgeon or the specific medical oncologist who they wanted to see. But I would say that overall the volume tensions there evened out. The COVID concern weighted for us approximately equivalently to the site preference. So I would say, although individual patients made different choices, as a system, we were able to move patients to the site where we thought they should be cared for.
Yeah, in our experience at Penn was very, very similar to that. We had some patients who wouldn't come downtown, literally if their life depended on it. It was one of our concerns because, in fact, some of them wouldn't go anywhere for care. And I think we've all seen patients who have come in with much more advanced disease than we've been used to seeing. So the fear was real. And we had some pretty interesting conversations about the fact that in the end, we felt that our safety procedures were equivalent downtown as with our suburban sites among ourselves. And we really believed that. I still believe that. But the patients didn't always believe that. And so part of it, I think, is really a reflection of what Effie said, which is you just pick up the newspaper to watch the evening news and they talk about the patient counts in our downtown hospitals, and they were pretty staggering. So patients did, really vote with their feet. But I think we felt it was our responsibility to make sure the patients were getting the care that they really deserved to get. And That was part of why the tumor boards increased in frequency, why there was more interaction among our clinicians at the different sites. We tried to be sure that if there was something that they needed downtown that we couldn't give them at one of our other sites, that we tried to make that happen. We tried to talk to the patient, make them comfortable. But we also really had type of interaction that I think allowed many patients to get the same care at any one of our sites that they would have gotten downtown. I guess the one other thing I would mention is, there are things that were only done downtown. Allogeneic bone marrow transplants and CAR T cells. So we're actually going to start moving CAR T cell therapy out into our regional hospitals. That's another story. But part of the same phenomenon is moving specialty care out of downtown Philadelphia. And we had to work specially with those patients because they were not going to get their allo transplant anywhere else other than at our downtown.
That's a great point, actually. We had specific considerations we put into place where all of our floors at the hospital end up becoming COVID mixed, some COVID positive and COVID negative. But we were able to get an exemption from the hospital that our stem cell transplant floor was COVID negative. It was a bit of a marketing effort in that we wanted to be able to continue to ensure patients who have other allo transplant centers available in town that we were doing everything we could to protect them. But there were political considerations that played a role in the way that we allocated patients across our different locations inpatient.
So I have a question about, you talked a lot about your moving your higher end care into the satellite locations. And I know that it wasn't as if you had a long time to prepare from a standpoint of getting people up to speed. You talked about providers and some of the things that you did with them to provide a higher level of confidence that, it was a good transition. But what about for other staff, especially I'm interested in the infusion staff and other people that were involved in this shift. Did you have issues with competency, training, education, resources that as you turned on a dime, you had to address that were unexpected for you? And
I can start there if you'd like. So for one thing, we actually have a uniform oversight of all of our infusion units by a woman named Lindsay Zink. And so all of our procedures and so on were the same really at all of our sites. And there were certain medications that we were more familiar with giving downtown, but not many. And there was tremendous communication back and forth between the nurses. The other thing that happened was that our infusion volumes, as I mentioned, were down substantially at our largest site, our main downtown site. And we actually redeployed, if you will, those infusion nurses in several locations, one of which was actually providing home care, home infusion. And at other times with the Best Practices Committee, we talked about our cancer care at home program, but we had to increase those numbers rapidly. We couldn't hire that many nurses. We just moved the nurses from our downtown infusion sites into other sites. But a really good question.
Yeah, Theresa, this is Beth. So I would say that we didn't have concerns about the competencies, but like Larry mentioned, one of our challenges was a lot of our ambulatory nurses were redeployed to the inpatient setting to help on the inpatient floors. And so we were challenged to ensure that we had enough staffing in the outpatient setting to meet the needs of the patient that were coming in. And so we too, like Larry said, had our staff managing across sites and kind of partnering together to kind of go to a different site if necessary to ensure the patient received the care that they needed. So it was a little bit of a different twist, but no concerns about the competencies or the care because it's all staff that work under a similar structure. But it really was challenging to manage the ambulatory volume in Boston when we had so many nurses and APP redeployed to the ICUs and to the COVID floors that we really struggled to ensure. And the nursing team and the APP leadership team did a phenomenal job managing all those challenges that we faced for a really long period of time.
Thank you. Dr. Shulman, you made a comment just a minute ago about the home infusion initiative at your center, and a question coming in about, do you see that you will continue with that? And could you talk just a little bit about what your plans are in that regard?
Sure. It's a great question. So again, this is one of these things where we started a new program with home infusions before COVID, a few months before COVID, having no idea what was going to happen. And it was a neat little research project with a small number of patients. And then when COVID hit, we literally pivoted on a dime and ramped up the volumes. Patients were much more anxious to have therapy at home. Seemed like a great idea to them. We were very anxious to keep patients out of our facilities if we could and still provide them the care that they needed, so that there was really an explosion of in-home care that we provided, again, partly supported by our infusion nurses from our ambulatory units. And we also, got some of the fellows to help organize it. I mean, it was a big team effort. But frankly, the patients love it. For some of the stuff, it's really simple. Somebody's getting a Lupron injection. Really, drive an hour and a half, try to wrestle with parking, wait, 40 minutes in the infusion unit, have to wait for the valet to bring your car back and drive home. Whereas a nurse can show up and give you the injection in 45 seconds. So some of there's some things that it's not right for, but there are a lot of things that it's really better for. And one of the things we've been doing is working with the payers to try to make sure that we have a reasonable financial compensation, if you will, for doing that, because it is a shift in revenues. It's a shift in the way things get paid for. And we do have to stay financially afloat. But clearly, it's a very, very good thing for patients. And we now have an operational team that's focused entirely on making sure this keeps going and going optimally.
Such good work. Thanks for pushing the envelope for the rest of us. Dr. Hochberg, there's some traffic about the MIT utilization model, and you talked about that, felt it was efficient for infusion scheduling and really eye-opening about where your capacity challenges could be and where you could ship patients. How did it resonate with patients? What kind of satisfaction or lack of satisfaction was embraced by the patients with this?
So I think, as with most downtown infusion sites, traffic and the ability to get in and out of the city is a major concern for patients. And that really results in this middle of the day peak for us. And one of the big benefits that we had two different benefits on that curve I showed you for the opt-in. One was trying to make sure the right infusions were running in the middle of the day to ensure that we had long infusions, less start and stops, take advantage of our mixing capacity at various times of the day. But the second one was moving patients out to the tails of the day. I would say that if we got it to the right patients, there wasn't much pushback. We could get patients in before the traffic got bad and then get them out when the traffic was okay after rush hour. It worked okay. But trying to get people to drive into Boston for a 9 a.m. or a 10 a.m. infusion, sitting right in traffic for an hour, was quite difficult. That's a challenge we still continue to face. Our hope is that by offering infusion appointments across each of our sites, we can overcome some of those barriers and get the infusions closer to where the patients are. Best of all would be Dr. Shulman's strategy of getting the infusion at their own home.
Thank you. I'd like to hear from each one of you about strategies that you are employing now to keep the providers engaged in the changes that you made during the pandemic. The telehealth, the telehealth responsiveness from the providers, the ability for the providers, to your point, Dr. Hochberg, about moving to, traveling to other locations. So what are you doing to hardwire some of these things so that that engagement and activity remains a part of your future?
Maybe I can start with that. So I think there's a couple different pieces of it, and I don't know that we've gotten it right yet, but part of it is building into our compensation plan models that that at least keep equivalent the physician's salary impact from the ways in which patients can be seen. We'd love to use that as a stronger driver for the way in which we can move individual providers toward the kinds of care we want to deliver. I would say, though, that finances are not always the strongest driver for physicians who are very busy and who have academic careers. In some of those cases, we have to offer them the opportunity to do what they want to do, see patients in person at one of our network sites, and to rely on their goal of providing exceptional medical care in person and give them the opportunity to do that at a specific site, not in Boston the way they always have. So those are some of the ways in which we are doing it, by constraining our total in-person capacity and offering each individual physician and APP team the opportunities to expand into the areas that we want them to expand into. They make the choice and they're more comfortable with the place they end up.
And then to complement that, one of the other things we're doing as well as Theresa is we actually have data that we're sharing so that we can kind of show how we're doing to where we want to be. And I think, you know, we don't always like to use data to kind of drive some of the behaviors, but we've had to use that to model this out for regarding expectations of how we manage clinic operations, particularly in the Boston campus. So I would say that's been helpful in some respect to share where they were, and then question, you know, why have we transitioned from a disease center that was 70% virtual during the pandemic, and now we're dropping to 50 to 40%, and helping us understand what the sea change was, and understanding those components. But it's been, as we know, it's been a challenging year plus, and I think everyone wants to get to normal life as things start to open back up. So it's a lot of opportunity, and I think the big thing as well as we mentioned in our presentation is we've realigned some of our space, which has also asked our programs to think strategically and differently about how we use our Boston campus and our other sites, which was in and of itself a change that we evolved and have had lots of conversations about the reasons behind that we're still actually working through each and every day.
I would just add, I think the biggest change that I notice, and I think the most important change is the bonds that have developed between the downtown oncologists and our community oncologists. And yeah, this has been going on for 15 months now. And you know, we've had 15 months of connecting at tumor boards, getting to know each other, you know, often doing it, you know, from your home with your kid or your cat running around behind you. And we've gotten to know each other in a different way than we would have known them before. And you know, and it's palpable, you know, it's real. And I think that's changed the way we think about our system overall going forward. You know, one of the existential questions or discussions we've been having, if you will, lately is, should we return the tumor boards to in-person tumor boards? You know, we can probably do that in the next month or so if we want to. And there's certain advantages. I think many of us miss sitting around at the table and, you know, chatting with each other and talking before and after tumor board. But the virtual tumor boards have put everybody in equal stance, and it really has changed our relationships. And so we don't know what we're going to do yet, but we're very, very anxious to preserve and, in fact, continue to grow those relationships.
Thank you. I have one final question before we end, and that is, God forbid that we would have another round of challenges that we've had in the past with this pandemic. Is there anything about the strategy not just strategy, but strategies and techniques that you put in place to deal with this event that you would modify if it happened again?
Well, I would say, and I should know what happened in Boston because my son is a physician in Boston, but we had a huge spike again in December and January. You know, it was a remarkable difference between than a year ago. We knew what to do. We knew how to keep our staff safe. We knew how to keep our patients safe. We knew how to utilize our space better. And, you know, frankly, we weren't so overwhelmed emotionally or any other way by what was going on. It was quite frightening. We didn't know where it was going to end up, but we adjusted quite well. And it was a totally different phenomenon. We weren't sure we would do as well as we did. And so we were on our toes every day, if you will. But clearly, we were able to manage the second spike that we had much, much better than we managed the first.
I would just add that I think we did a good job with communication the first time around, talking about what we thought was going to happen. But the more transparent we can be with our staff, the more they understand the spectrum of options available to us, depending on what happens with the surge, the more they understand about our planning, the less these changes come as surprises and the less frustrations we would hear from our physician, nursing, and APP staff. So I think we were quite transparent, but we could be even more transparent about exactly what we're thinking on a daily basis if people want to hear how we are analyzing the news and thinking about how operations might change. That would probably decrease frustration.
Beth, is there anything you'd like to add?
I think one of the things that I would just mention is, Theresa, as I alluded to in our presentation, is, you know, we took one of our suites and made it a COVID unit for the hospital, but also out of the need to do this for our oncology patients. And I think if I looked back, I think it was the right thing to do, but it certainly presented significant challenges, and we're still actually running that operation for our institution in a much smaller footprint. And I think we've made it work. But I think, you know, it was something that I might rethink in the future going forward if we were asked again, but I do believe we did it because of the need for our cancer patients to get the best service in our suites and not have it happen in another place in the hospital. But I think that's one of the things that, looking back, I think, you know, given that we're 15 months later, we're still running this unit for the hospital, and we don't know when we're not going to run it. It was the right thing to do, but I don't know that we should do this going forward as we continue to evaluate the pressure that placed on our team, because our team was not only caring for oncology patients, we were caring for COVID patients in our suite, and our staff was the staff that was managing that patient activity as well.
We also created a similar unit, Beth, early on, one of our floors in our ambulatory infusion unit, but we were actually able to close it down after about five months.
Great, thank you. I want to ask just one final thing, just very, very quickly, but any insight from the patient satisfaction scores or anything during this period with all this movement to your satellites that provided you with any improvements that you tried to put in place during this whole transition, or anything that caught you by surprise where that was concerned?
Theresa, I would say the two most positive things were, one, the patients really appreciated that their providers were actually going to the site to see them, so they could see their same doctor at the site, and we've continued to evolve that model, as you see in our kind of long-term strategy. The second piece that was a huge success was the opportunity for virtual care. And I think what we're seeing now is, given that our restrictions have come forward with our MGB oversight asking us not to see patients out of state in which a physician is not licensed, we've seen a lot of actually negative impact to our patients from that decision, which we respect. But I think that was one thing that was very, very positive for patients, was virtual care. So I think we're going to continue to look at how we can evolve that. But those were two things that we've gotten very positive feedback, and now as some of that has changed, we're certainly struggling with the need to make that switch.
I would just add that, you know, we suspended press gaming, so I don't have any actual data to show you about what patient satisfaction was during the pandemic. But anecdotally, I think our patients really appreciated the efforts that we made to keep them safe and keep them cared for, and keep them cared for in the right places. I would also echo what Beth is saying about telemedicine, which has clearly been so good for so many patients in so many circumstances. We have actually done formal surveys of patients in some categories that are getting telemedicine, and it's very, very positively received. We've had the same problems with cross-state telemedicine that Beth described, and I'm very, very concerned about that's going to go from legal and reimbursement point of view in the coming months. So lobby your congressman. And it's really a critical point.
Agreed, agreed. Well, I would like to thank you for the broad brush that you were able to paint about your work through the pandemic and utilization of your satellite locations. I think you gave us a real opportunity to look within our own cancer centers and think about how we can start to push the envelope on things that we thought we might just put a Band-Aid on during the pandemic, but you've really shown us that there's a lot of opportunity for some of the things that you've done to really have legs into the future when it comes to really providing excellent cancer care. So thank you for all of that. And I'd like to thank all of the individuals who participated in this webinar, and once again for the supporters, for their charitable contributions for us to be able to do these kinds of things. So thank you all for that as well. So with that, I'll wish you a nice evening, and thank you all so much for joining us, with a particular thank you to our presenters.